virtual chapter policy forum. We currently right now have about 17 chapters throughout the U.S. and today will be chapters throughout the U.S. and today will be the New York City and Philadelphia chapters that will be talking. And I want to introduce myself. I'm Dr. Diana Torres-Burgos, Chair of the New York City chapter. I'm also a Hispanic Health Advisor for the National Hispanic Health Foundation. And Dr. Lopez, would you like to introduce yourself, please?
Hi, my name is Ana Maria Lopez. I'm a medical oncologist at Jefferson, Sidney Kimmel Medical College and Sidney Kimmel Cancer Center. So, longtime NHMA board member, NHMA fan. We're currently in the process of putting together a chapter in the Philadelphia area. So all of you who are in Philadelphia, please reach out to NHMA. Let us know of your interest.
Thank you, Diana and Ana Maria for being the chapter leaders of New York City and Philadelphia for the National Hispanic Medical Association this year. We're very happy to have these events in September and October to be able to share policy priorities and leadership examples with our membership across the country this year since they're virtual. I just really wanted to tell everyone that I've been involved with the U.S. Department of Health and Human Services Vaccine Consultation Committee with one of our board members, Dr. Maria Carrasco, also helping. We represent the Latino doctors, and we have given our support to the importance of the National Institutes of Health working with Moderna on the clinical trials for COVID-19 vaccine. The website to find where you can enroll or tell your patients to enroll is coronaviruspreventionnetwork.org, and it has a lot of information about what you have to do and you know, to get the vaccine, a very small dose of a vaccine or a placebo. They actually give you 2 different shots 3 weeks apart and follow you. And it's very important to know that they're very interested in having more diversity in the clinical trials. They've already gotten about 15,000 people enrolled. Their goal is 30,000, and they're hoping to have a vaccine available by the end of the year. The other clinical trial that we're working with is Pfizer's clinical trial. They have a multicultural advisory council, and NHMA was invited this year for the first time. I think it's been around 3 years. And that website is covidvaccinestudy1.com. And again, Pfizer and Moderna are 2 companies out of about, I don't know, a dozen companies that are actively working on clinical trials. And the other thing I wanted to let you know is that we have a scholarship with our foundation, the National Hispanic Health Foundation. This year we're having one event, a 2-hour ceremony, 1 hour reception, 1 hour ceremony, excuse me. And that is going to be on November 19th from 8 to 10 Eastern Time. We are honoring the Surgeon General, Jerome Adams, and the hospital executive from the New York City hospitals, Christina, I believe her name is Carrera. Sorry, I might have that wrong. Another hospital doctor in charge of a residency program at the White Memorial Hospital, Laura Tureen. The president of the Hispanics in Philanthropy, Maria Archipelago, and also the medical officer for the American Heart Association, Dr. Eduardo Sanchez. And I think we will have a great event. We've got about 40 scholarships that we're giving out this year. And I invite you all to go to our website, the NHHF, which is nhmafoundation.org. And then lastly, our conference 2021, we have dates, March 17th through the 20th. We're starting with an opening reception on a Wednesday night. The conference will be all day Thursday, Friday, Saturday, with the closings being our award ceremony Saturday evening. And The agenda is now up, and we are actively looking for the speakers to fill in some of the gaps. We have a call for speakers, call for posters and sponsors for the event. So I just want to thank you all, and thank you all for New York City's and Philadelphia's audience and others joining us tonight. So Diana, back to you. Thank you.
Thank you so much, Dr. Rios. So again, I introduced myself. I'm Diana Torres-Burgos. I've been with NHMA for many, many years and now chair the New York City chapter. And just before we get started, I want to go over a few housekeeping issues, and that is that all the presentations will be followed by about a 15-minute, and if we're on time, 20-minute discussion. The microphones during the presentations will be muted, and we really encourage that you have any questions, so please put it in the chat box. We will get to those questions as best as we can at the end of presentations, and we do welcome for it to be more interactive. This webinar is being recorded and will be available on the NHMA website at www.nhmamd.org. You will be able to receive CME, and that CME will be available up to a year on the NHMA website. Next slide, please. Before we begin, again, it's important that we stress that there is no conflict of interest disclosures by all the speakers. As you have listed here, these are the objectives, and that is to describe racial and ethnic disparities in COVID-19 in New York City during the peak of the city's pandemic, describe the challenges faced by Hispanic Latino populations during the COVID-19 pandemic, discuss health equity and the challenges of providing not only obstetric care, but also mental health and primary care to vulnerable populations with a focus on Hispanic populations. So, as I mentioned, we are going to be discussing tonight the impacts of Latinos due to COVID-19 and reflections from some people that were on the front lines. For those that were expecting Dr. Raul Pereira-Henze, he unfortunately had a family medical emergency and will not be able to be with us tonight. He was the Deputy Mayor of New York City Health and Human Services. However, myself and Dr. Lopez will try to cover some of the information on the stats and the impacts on Latinos due to COVID. So without further ado, next slide, please. So as you know, there's been a lot of news on how the Hispanics and the African American communities have been impacted, as you see here. And it was noted from the very beginning that they were among the highest populations that were impacted. And there have been several studies, such as the Penn study, showing a disproportionately high infection rate in Black and Hispanic women. There was also a CBS special talking about particularly the immigrant community and farm workers and how they were impacted. So as you see, these are all headlines that we've probably all seen and read, and so this has become a very significant issue for our community. Next slide, please. So the CDC has been monitoring and tracking cases, hospitalizations, and deaths, and they continue to track that. And they they started initially adding race and ethnicity because many people thought it was very important to see if there were any populations that were particularly being affected by this. And this is the data we have so far according to the CDC as of October 11th, 2020. And that is that of the US cases by race and ethnicity, Hispanic Latinos are 28.4%, Black non-Hispanic are 17.7%, and white non-Hispanic are 44.4%. When you look at, next slide please. When you look at the hospitalizations, again, by race and ethnicity, you could see overwhelmingly that COVID-19 associated hospitalization rates are the highest among Hispanic Latinos, non-Hispanic Black, non-Hispanic American Indian and Alaska Native when you compare to non-Hispanic Asian or Pacific Islander or non-Hispanic white. Next slide, please. When you look at the US death rates by race and ethnicity, again, this is data, and I forgot to mention in the previous slide, when you look at cases, very importantly, race and ethnicity data was only available on cases for 52% of those cases that were reported. For deaths, it's 82%, but what's important is that we are getting incomplete data because it's not all there. When you look at the US death rates, it's 16.4% for Hispanic and Latinos, 20.7% for Black non-Hispanic, and 52.9% for white non-Hispanic. This is as of October 2020. However, this, when you compare it to the current population, you would say the current population for Latinos in the US now is 18.3%. So you're saying, okay, it's 16.4, so not similar or near the population. However, next slide, please. The CDC, although it's reporting that, when you look at some geographic areas where there are large concentrations and populations of Latinos, the death rate is more higher, and on average about 26.8. Part of this is due to the uneven reporting, of course, across the states and the counties, so we don't have full data. In fact, when the pandemic started in April 2020, only 22 states were reporting racial and ethnicity data. Now it's required for most states to report it, and 38 states are reporting distribution of cases by race and ethnicity compared to the population, so that we can know what's happening in certain subpopulations and are they being disproportionately impacted. Next slide, please. Next slide, please. Here is a map of New York City. When you look at the colors, it's the first map is the case rate per 100,000 people. The second map is the death rate per 100,000 people. In terms of color, the very, very dark purple is the higher number. The lighter purple is the lower number. And what you can see from this is that the Bronx was the most affected borough in New York City. You had certain areas in Queens, and I'm sorry, I do not have a pointer. And you also see this rectangular little square between Brooklyn and Queens with a little gray at the tip. That is East New York. East New York has the highest case and death rate in all of New York City. And what we find is that neighborhoods that have high populations of Latinos, African Americans, and low-income residents are ones that have the highest in terms of rates, case, and death rates. And when you look at both of them, they're very similar. And as I said, these are the areas that were most impacted due to the several reasons we'll discuss later in this presentation. When you look at Long Island, Far Rockaway was the other area that was very much impacted by COVID. Next slide, please. So that's a little bit of New York City. Again, we just wanted to give you an idea of what the stats were and to show that there is evidence that Hispanics and African Americans were very disproportionately impacted in New York City. And with that, I will pass it on to my colleague, Dr. Lopez, to talk about Philadelphia and Pennsylvania.
Thank you. Thank you. Great, great slides and presentation. So definitely, we want to look at the demographics. Who's getting infected and what are the outcomes of the infection? And I think what Dr. Torres Burgos mentioned earlier is really important, that if we look at data from Pennsylvania, what do we see as the most common ethnicity? Not reported. So that really makes us wonder about not just the quality of the data, but really what can we really gain from the data? So very important that this observation was made, and then there were efforts to rectify it. Next slide, please. So again, this is the COVID dashboard, and the COVID dashboard really tried to first to be established after the governor said, this is important and these data need to be collected. And although here we see by ethnicity, Hispanic, not Hispanic, or Latino, not Latino, we see a big difference. Again, you have to remember that there was a large amount of data that did not have this information. The data for incidents from the laboratories usually don't collect this type of data, don't collect demographic data. So certainly the mortality data would be more complete from that perspective. Next slide, please. So at the end of April, the governor's mandate to record race ethnicity, because about 70% of data were not reported and almost no data on ethnicity. So again, really thinking there's race, there's ethnicity lacking in many, and about half the states did not report at all. Next slide, please. And I think people did say things like, well, what does it matter? Everybody's at risk. And of course, that is a point, but it's really important for us to know so we can target prevention efforts, target therapeutic efforts. Now, what do we find in areas where we do have the data? So an area that had always been collecting information was York City, Pennsylvania. The population, about a third Latino, confirmed diagnoses more than 70%, 71.6%. So certainly making us wonder, what's the difference here? This is definitely looks like an at-risk population when we have data. Next slide, please. And there's several hypotheses, and I'll share some of these with you from the US Bureau of Labor Statistics. If we think, where are Latinos working? They tend to be in essential worker positions, 27.3% in construction, 23% in agriculture, 22% in leisure and hospitality. I wondered if healthcare fit under leisure and hospitality, but because there are, many that are, and especially women in healthcare. So where people work, the fact that their risk, their exposure may be higher. Next slide, please. So we begin to start to map out an idea, a hypothesis of why Latinos may be disproportionately impacted by COVID. This could relate to employment, could relate to socioeconomic inequities, and actually the next slide, I will have this in fuller detail. So let's just go to the next slide, please. So we've talked about being essential workers, and some of these jobs may not have access to insurance, may not have access to sick pay. So that would make it less likely for people, number one, to go get tested, less likely to say, I need to take time off because I have this illness. So the link between employment and socioeconomic inequities is very important. I really like this slide because it makes us think that we all live in a matrix and that these factors can be very interlocking. So employment, yes, but even if you're employed, that can lead to inequities, which can lead to decreased access to healthcare. And we all know that these multiple social determinants can have an impact here. People were losing jobs, people were losing insurance, people live in multi-generational homes, which can have so many benefits, but may increase risk to the virus. So in the thinking, there's not just one area to address, but multiple. Next slide, please. Risk, the slides are in a slightly different order, but so there are risks, there are opportunities for us. We've mentioned some of these, the lack of data, but we are making lots of efforts to have a more diverse workforce, to have patient education materials in Spanish, and really for all of us as we are coming together now to partner, to advocate, and to try to address this problem together. Next slide, please. Thank you.
Thank you, Dr. Lopez. That was great. I do want to add that one thing that I was very surprised to find is that Latinos have less of an ability to work from home. It was very interesting that the Bureau of Labor and Statistics had where Latinos were 13% with the ability to work from home, as opposed to 27% for everybody else. So that really was a real issue in that they not only had to go to work in person, but they were being exposed to all these areas, whether it was transportation or anything, where again, they were higher risk for getting, you know, infected with the disease. So I just wanted to add that, but thank you very much, Dr. Lopez, that was great. And again, those are just some of the possibilities, and we're hoping that we are able to, by the end of this webinar, also come up with ideas of what we can really do to particularly protect our communities in this coming second wave that a lot of us are now experiencing. So without further ado, I'd love to present Dr. Susana Morales, who is the director of the Diversity Center of Excellence at Cornell Center for Health Equity at Weill Cornell Medicine, and she'll be talking on COVID-19 disparities, exploring the issues. And Dr. Susana, you're on.
Hi, everyone. Can you hear me?
Yes.
Are you able to hear me? Sorry if some of this is redundant, and my Zoom zoned out for a few minutes at the beginning. So forgive if there is redundancy. So in thinking about why COVID has been so catastrophic, obviously there are issues around the organism itself and the disease itself that are obviously very problematic. You know, it's a novel organism, so that there is no prior partial immunity, unlike the flu. Even though there are other coronaviruses, they don't seem to be protective. And of course, it's much more lethal than the flu. The fact that COVID is spread by respiratory droplets and also by fomites, which is by touch, although the touch thing seems to be less. But recently, the WHO and CDC found it also aerosolizes, which is different because aerosolized COVID organisms float in the air for a prolonged period of time after the person may have left. So it's not just somebody coughing on you. And that, I think, adds to the incredible contagion. The fact that there's an asymptomatic infectious interval, or that there are asymptomatic infections, makes it much more transmissible. And of course, we have no adequate treatment or vaccine. The fact that I was seeing that it is definitely that the symptoms are similar to other respiratory illnesses, so that could lead to delays in diagnosis or misdiagnosis. For example, I had several asthmatics that thought that they were having an asthma attack, but really they were developing COVID, because in the beginning we didn't really know. And honestly, it was very interesting to experience as a primary care doctor. Initially, when patients were calling and saying they were coughing but had no fever, I was reassured by the absence of fever. Now we know, at least in our series of patients at Cornell, our first 370 odd patients that were admitted here to NYP Cornell, only half of them had potential for misdiagnosis, and of course, or delays in diagnosis. The fact that COVID has such a myriad of manifestations, not only the respiratory catastrophes, but also the risk of clotting disorders, cardiac problems, neurological complications, make it a great imitator. Many patients would only present with gastrointestinal problems, so that the clinician might think that they had gastroenteritis. I had patients presenting only with back pain or only with some aching. So it's a masquerader, and that has been, I think, part of the problem, especially initially, with keeping on top of it. Next slide, please. Then there are, as has been mentioned, some characteristics of patients of the host that make it potentially more or less dangerous. Clearly, there's either or to severity of infection. They may be have compromised immune systems. Older people have more compromised immune systems, and now we know that other underlying factors, as has been mentioned, diabetes, other respiratory illness, and obesity. Even hypertension seems to be related, which was a surprising finding. So there may be certain characteristics of certain hosts that might make people more susceptible to getting very sick. And then the phenomena that I think we've seen in terms of COVID disparities, and especially related to Latinos, the behavioral aspect. So there may have been lack of social distancing. In part, I think there was a lot of misinformation, especially in the beginning, and very poor public health messaging, including culturally and linguistically competent messaging. Many patients would delay seeking care, and that's a behavioral phenomenon. So part of that may have been, as I mentioned, not really understanding what was going on. In the very beginning, of course, we didn't really understand it. We were telling patients, don't go to the hospital unless you're short of breath. But what we discovered later is that many, they were gravely ill. There were also delays in seeking care because of fears of going to the hospital. The fact that certainly in New York City, and I think it's true around the country, that you were not allowed to have visitors, which was obviously needed for infection control reasons, but people feared, I'm going to go to the hospital and I will never see my loved ones again. And that definitely deterred people from going to the hospital. There's fear of cost. There were some, I certainly had discussions with patients about fearing what was going to happen, how much is this going to cost. Fear of the authorities, as I think has been mentioned, especially if you were undocumented, and then suspicion of authorities. We're seeing outbreaks now in some Orthodox Jewish communities in New York City, for example. And that may be related in part to a long, tense relationship with the secular authorities and concern about discrimination behavior. Next slide. The population density, as Dr. Burgos showed, we know that disease, especially in the beginning, was concentrated in large cities, although now, unfortunately, it's spreading all over the country, including in the rural areas. But that first wave was definitely concentrated in large cities, and the household crowding phenomenon, and as mentioned, multi-generational homes, were more concentrated in the Bronx, Queens, and Brooklyn. We know that certainly in New York City, essential and service workers were often people of color. The risk related to public transportation, we certainly have seen many people terrified of going to public transportation, and in the beginning, since there was no masking, I think that was a very big risk. For many people, what we were seeing in the beginning was people were thought to have COVID. We could not test them because there was no testing capacity. We told them, go home and shelter at home, but there was no way for people to shelter at home because they lived with other people, and no matter how hard you struggle, and in the very beginning of the there was no provision made for that reality. A little further into the epidemic, there were hotel rooms that were used to house people that couldn't go home because of their other family members and concerns about being able to protect the other family members, but that did not happen in the beginning. Many people, as has been mentioned, have no paid sick leave, and mass gatherings, of course, I have personal friends and certainly many patients that developed COVID probably related to funerals. There have been mass gathering weddings associated with COVID. So, and of course now there's a controversy about political rallies being a way to spread COVID. Next slide, please.
Some of the other factors that obviously have contributed to making this pandemic so catastrophic, of course, there's the failed federal response, the lack of urgency, the lack of coordination, the terrible messaging, and misinformation, disinformation. Unfortunately, there have been very inconsistent state responses. I think New York State, although there was infighting between our mayor and our governor, in New York State, the state response was appropriate, aggressive. The lockdown was complete, and there's been a very thoughtful process and united plan between the governor and the public health authorities, but that has not been the case around the country. And so in parts of the country where the outbreak is not controlled, there's still been urgency about reopening schools, reopening restaurants, and so forth, which I think has disproportionately harmed our communities. The lack of testing capacity, that's very interesting, what you were saying about many patients fearing a test. I have not personally seen that as much, but definitely in the initial weeks of the pandemic, because, for a couple of reasons, the lack of testing materials, the lack of PPE, there was an incredible move to conserve all of those things. And so we had a fever clinic that was in essence a COVID clinic, and we would tell people, I'm 99.9% sure you have COVID, but we can't test you. And it was maddening for patients. They desperately wanted to know. So it's really awful. And in the very beginning, the tests were slower. And then in different parts of the country, the test results have been extremely slow, again, because of the lack of capacity. But if the slower the test, the more useless it is. If people are potentially infecting other people and don't know that they're sick, it's really been catastrophic. In New York City, what we saw, unfortunately, was that when testing was available, it was not initially targeted to the highest risk areas. And as we say, the retrospective scope, things are obvious when you're looking back, but it was, it seems obvious now that the highest hit areas were high risk because of all the things that we've identified about social determinants. And that lack of targeting was very unfortunate. The delays in the lockdown and school closures and restaurant closings, certainly in New York City, was really frustrating. Many public health experts were pushing the government to make the decision. It's clearly a huge decision to shut down one of the biggest cities in the world, but it needed to happen. And the feeling is that if the city had been locked down even a week earlier, that many, many, many lives would have been saved. So that's a tragic delay. The lack of contact tracing, there was, the dilemma in New York was because you couldn't test, you obviously could not do contact tracing. And there was no real robust contact tracing apparatus. And then there was a lot of political back and forth about who should run contact tracing, and that was also unfortunate. An entire contact tracing apparatus had to be set up almost from scratch in a different agency, in the Health and Hospitals Corporation, instead of the Department of Health. Which was quite controversial, but there have been a lot of issues about contact tracing, about people's fears of having their information disclosed, the realities of the difficulty of reaching people on the telephone, people not answering the phone, people not wanting to reveal who they've been in contact with for various and sundry reasons. So that there have been many barriers to contact tracing, although it is one of the most fundamental tools in controlling an infectious disease. The lack of PPE was a huge problem in New York City, and it's still an issue. Our hospital has stocked up a lot now, getting ready for the next wave, unfortunately, but we are still preserving PPE. And of course, in the worst points of the pandemic, there were definitely hospitals that were running out of PPE, that were using garbage bags, et cetera. And the delay in recommending face covering was complicated and has continued to be obviously a huge controversy. There is no question that it helps prevent infection. There are all kinds of sociological issues around people's unwillingness to use face covering. It's now become politicized as a political statement instead of a public health statement. That is really a catastrophe. And it is still being seen as an issue here in New York City, where we have a lot of mask use, but not 100%. Next slide, please. This is a picture of the line outside of Elmhurst Hospital to get testing. So there was definitely desperate desire for testing in New York City, especially during the peak times of the pandemic. Next, please. There are a lot of healthcare delivery factors in terms of why our communities were especially hard hit. In addition, our safety net institutions, which disproportionately serve people of color, have always been undersupplied and under-equipped, and then it just got worse under COVID, especially at the peak. There's always been problems with quality of care, mainly because of lack of resources, not because of the lack of commitment and amazing desire to help by the part of staff, but just the lack of access to resources. One of the things that happens when you have pandemic catastrophic lack of resources, though, in addition, is the potential for bias. Of course, frequently just unconscious bias, but if you're deciding who you're letting go home and who you're not, how much is unconscious bias potentially at play in who you tell to leave, who you send home from the emergency room. There are issues around how the emergency medical service worked, the ambulance service. The EMS was absolutely overwhelmed, and their mission was to just scoop and carry to the nearest hospital, even though that meant that they were already being brought to already overwhelmed institutions, so that the hospitals within the worst hit communities were also horribly hit. And then there was the phenomenon where EMS was having to make triage decisions in the field. They would go, I know for a fact, I have a couple of patients that ended up having had COVID that were told, you're not sick enough for us to bring you to the hospital, and they were left home. Luckily, at least these couple of people that I'm describing lived, but how many people potentially didn't because of those almost impossible triage decisions that EMTs were having to make in the field. There was a lack of access to primary health care. All of our primary health care was pretty much closed down. We did have a fever clinic, but patients were told to stay home unless they were really sick. And so that one of the concerns, so we did a lot of telephone medicine. We also tried to use telemedicine, but our low-income patients, our elderly, and otherwise people that didn't have a digital divide did not have resources to use telemedicine. The nursing home issue was huge in New York, and the home health aides. The home health aides as both victims and vectors. Next slide. And I'm going to wrap up. Next slide. So what I think we need to do going forward, obviously we need a national mask mandate. We need aggressive public education about what's truly needed. There needs to be a coordinated national testing plan, including the production and distribution of testing materials, which has not happened. Contact tracing, I've mentioned. There needs to be a national plan for PPE, surges, ventilators, which has not occurred. Nursing homes have been a source of disproportionate death, and that they need to be really assisted. And then now we're dealing with the survivors. Just because you survive the initial first wave of the disease doesn't mean that you're well, and many of our COVID survivors are still quite sick. And the mental health impact on providers, on communities, on survivors is really important. And I think we need to have an aggressive focus on trauma-informed care, mental health services, et cetera. Thank you.
Thank you so much, Dr. Morales. That was great, and definitely very good recommendations that everyone should be looking at. And so I want to introduce Dr. Jack Ludmir, who's Executive Vice President for Equity, Associate Provost, Community Engagement, Executive Director of the Philadelphia Collaborative for Health Equity, Professor of Obstetrics and Gynecology and Population Health at Thomas Jefferson University and Jefferson Health, Philadelphia. Dr. Ludmir, you're on.
Thank you very much. Good evening. Buenas noches a todos. Let me tell you, it's a real pleasure to be able to share this symposium with a distinguished panel. And I just want to thank Dr. Torres-Burgos and Dr. Lopez for the kind invitation. So I'm a maternal fetal medicine specialist that for the last 38 years has devoted his professional life to reduce maternal morbidity and mortality in Latin America. But for the last 20 years, we have been involved directly with the growing migrant population in this country. And I'm particularly going to address some of the numbers and the issues that we face with undocumented pregnant women. Currently in the US, an estimated 4 million of the children born are to undocumented parents, and most live in mixed status families. As probably everyone knows in this symposium, due to the 14th Amendment of the Constitution, if you're born in this country, you are a citizen. Although there have been some politics regarding this and the interpretation of this amendment, the fact is if you're born here, you're considered a citizen. The other important fact is that almost 7% of all the children born in this country, and we're talking approximately 280,000 children every year born in this country, have at least one undocumented parent. Can I have the next slide, please? So how about prenatal care for undocumented pregnant women? And according to the WHO, prenatal care should be a universal right for women, regardless of who they are, their ability to pay, or the country of origin. My own college, the College of Obstetricians and Gynecologists, has supported a basic healthcare package for all women, including the ability to give prenatal care without concern for country of origin or documentation. But the issue that we have is that access to prenatal care in this country varies widely across the country due to differences in state policies and different state level of interpretation of federal policies that fund health services for pregnant women. In particular for this audience, there are two significant differences between the state of New York and the state of Pennsylvania. In New York, the state funds and gives medical assistance to every woman that needs prenatal care, and that includes undocumented. In my state, in the state of Pennsylvania, undocumented pregnant women do not qualify for medical assistance to cover routine prenatal care. Now, in the rest of the country, there are two mechanisms to provide prenatal care to undocumented women. One is like New York State does, expansion of medical assistance for these women. And the other mechanism is an extension of CHIP, the Children's Health Insurance Program, under the umbrella of the unborn child, with the assumption that life starts at conception. For that reason, if we can provide insurance to any child born in this country, if life starts at conception, we should be providing prenatal care to the woman to make sure that that child is going to have a good outcome. So I'm not going to get involved in the politics and the ethics if this is correct or not, but this is a fact. And in particular states that are red states, like Texas, this is the mechanism in which prenatal care is provided to women. Now, based on these concerns, almost 15 years ago, I co-founded an organization by the name of Puentes de Salud that was mentioned on the chat with Steve Larson, that is an emergency room physician. And the reason for starting this group was to provide care to the growing Latino migrant population in Philadelphia. And besides Puentes de Salud, we've been able to start 2 different clinics, one called Latina Community Health Services, and now in my present job at Jefferson, a Jefferson Latina Clinic, in which we work with the community. These are free clinics. They are not supported by federal dollars or state dollars, and we depend from foundations or philanthropic dollars. And in the last 14 years, we have cared for more than 2,000 pregnancies, including a significant number of high-risk patients having diabetes, high blood pressure, multiple gestations, and these are women that don't have access to care. The next slide, please. Next slide. Now, in the last 2 years, we have seen a shift of migrants. Instead of until 2008, 2010, most of the migrants were coming from Mexico. After the recession in 2008, we started to see a shift of people coming from Central America. And we're seeing a significant number coming, in particular from Guatemala, Honduras, and El Salvador. Most of them are scared and frightened, and the majority escaping violence. We're seeing a significant number of teenagers. And these are, people, women that are really scared about showing up for prenatal care. Some of them have already experienced the terrible policies of separations of moms and children at the border. And some of our activities, if you're interested, have been documented by an HBO documentary by the name of Clinical Migrantes that you can get it through Google. The next slide. So just about numbers regarding COVID-19 and labor in Hispanic patients. And I'm just going to present 3 cities. In New York City, Colombia started to collect data in all patients that were coming to the labor floor. These are patients that were asymptomatic. And what they realized that of the first 100 patients that were positive for COVID, a significant number of them were Hispanics. And the greater proportion of patients coming to Colombia Obstetric Service that were affected with COVID, a lot of them asymptomatic, were Hispanics. In Boston, a study a little bit different. Instead of looking at all comers, they were just looking at patients that were presenting to the obstetric service with symptoms. And what they found out is that over 60% of the patients admitted to the obstetric service, and this is a study from Mass General, were Hispanics. And the population of Hispanics patients that they were seeing at Mass General was only 8%. So a significant percent of Hispanics with symptoms admitted to the labor floor were Latino Hispanic women. And in our own data, we still haven't published, of 103 positives, and this is universal testing at our labor floor when the patient presents in labor. The great majority of these patients don't have symptoms. What we found is that almost 36% of the patients were Hispanics, and a significant number of them undocumented. The next slide. So what have been the challenges of taking care of this population during COVID-19? How do we provide prenatal care when everyone was saying limited face-to-face interaction? And this population didn't have access to telemedicine for a variety of reasons. No broadband, no access to iPads. A lot of them didn't have smartphones. So no access to telemedicine, no access to transportation, no work, no school. So a real challenge. And what we opted was to continue to provide face-to-face and try to use phones as much as possible. But what we did is to open the access 24/7, meaning that there was a nice person answering your concerns 24 hours a day, 7 days a week. Not that you have to call a number and leave a message and wait for someone to call you. No, this was a direct call at 3 o'clock in the morning and answering. So there was tremendous amount of trust that we have built with constant education, because we were trying to limit the number of visits. And these are people, again, that don't have medical assistance, don't have resources. We were fortunate to have donors that gave us quite a bit of number of blood pressure cuffs. So we educated the population for them to check their blood pressure at home so they didn't have to come to us. And we got involved with them in social determinants, as Dr. Ana Maria Lopez was saying. The concerns for food, we established with different community-based organizations, food pantries, we were distributing food and diapers. So I just want to finish my remarks with the issue of testing that was mentioned before. Through Puentes de Salud, we got funding to provide free testing to the immigrant population. And what we have seen that the great majority of these migrants don't want to be tested. And the reason for them is that a lot of them are essential workers, either working in housekeeping or working in restaurants. And they're really afraid that by the fact that they are positive, they will have to be quarantined and they have to disclose this and they won't have a source of income. So it's really interesting. Even if you want to provide the service, the population has concerns about being tested. So I want to finish my remarks here, and I hope I will have chance for some questions during the Q&A. Thank you very much.
Thank you, Dr. Ludmir. That was great. Just to stay with time, we're going to have our next speaker, who is Dr. Pamela Montano Arteaga. She's director of the Latino Biocultural Clinic, Gouverneur Health, New York City Health and Hospitals, and also clinical assistant professor of psychiatry at NYU School of Medicine. So Dr. Montano, you're on.
Hi. Thank you so much for the invitation. I'm very glad to be here. I think after everything that the prior speakers have mentioned, no one can deny the impact of all of this has in mental health. I don't think anyone like in the community, as Dr. Morales mentioned, like providers, patients, or in general, we have been affected somehow by this COVID pandemic. And the issue was that mental health for the Latino population was not in the best shape already. We were already having issues because it's very, as other like chronic health issues, they are based on these social determinants of health. So if we have these issues, of course, it's going to impact the mental health. I think because some stuff has been already provided. So one of the things that is interesting for me is like, I know that we are trying to prepare for a second wave, but in mental health, we are not over the first wave. We have never been over. We are still there. And the crisis hasn't got better. It's just getting worse. So just the idea, and now with the idea the patients say, oh, things are going to get worse again, it's just like this anticipatory anxiety is just worsening stuff. So there were many variables. So maybe I can show like COVID, we call it like, it highlighted everything. All this is structural inequalities that minority populations have. So, and it highlighted in so many ways. Can you show me this next slide, please? So, as I mentioned, that's pre-COVID, all these issues, and then COVID came. So it highlighted everything. Next slide. So just starting with the illness itself. So you had a disease that it was new. People wasn't clear about what was happening. So that created a lot of fear of getting sick, fear of what recommendations they should follow, fear of like, if their like families were sick, especially when they start hearing that elder patients were more vulnerable. Also that they saw like I have many patients that, and you said that in first generation and also second and third generation immigrants that they had like a brother die, a cousin, like many members in the family. Sometimes they got sick themselves. I had like one of my patients, she's a mother, she and her husband got COVID. They got very sick, but they were like, as Dr. Morales mentioned, like I work for New York City Health and Hospital, so we are a public facility, and low-income patients, because medicine, because of these issues, they were like mostly doing televisits. So many of them, they were unable to talk to a medical doctor, or if they were able, sometimes they were no in Spanish, or they maybe culturally they were no, maybe it was no way, they were not giving the right information. So many patients thought, okay, they're just letting me die here. I'm going to die at home. And I had, for example, my patient that she just, she have a 5-month-old, and she was making her will, who was going to take care of her kid, because her husband and I, they were very sick. They were really bad, but fortunately they survived. But there was a lot of this misinformation that just created more fear. But also our population, many of people didn't have options. They needed to continue working. They needed to continue being exposed. We do like HAC, of course, we do the COVID test and the antibodies. And I haven't had one patient from the restaurant industry that goes to my clinic that has been, the antibodies have been negative. And we know that there are many negative. So I haven't, the first one, and I have done at least 30 patients, and all have been positive. So also a little bit like, I'm located in the Lower East Side, so we treat many patients from the NYCHA population, like a lot of like Puerto Rican, Dominican families, but also we are like next to a train that goes all the way to Brooklyn and Queens. And we also have many patients from the Bronx, because maybe they were born in our neighborhood and they moved to the Bronx. So we have a very diverse population. So maybe that also explains. Also, one part that is very important for the Latino community is family and unity. And even though we know as professionals that social distance was the best thing to do, this affected the families. Like, people were even like afraid to see their parents. And we are talking about people who, I had patients who already had trauma, already had mental health issues. So this all just got worse. So we also had like a decompensation of patients who were already having issues, and also new patients. And many other people who I know that they are not being treated at this time, unfortunately, due to resources. Grief, like, losing someone, and you're seeing like in the TV that so many people are dying, especially like when we saw like New York experience, like people have make an equivalent of the peak of the COVID pandemic to 9/11, how much like PTSD has created. I have patients who have recovered from COVID, but they are still like, they really have stress acute disorder symptoms, and also there is a lot of health anxiety. Like I had different like meetings with the medical team, just trying to make like a group plan, because a loss, it can be like mental health, but also COVID also has had some impact, and there are some like studies that the neurological impact, inflammation. So it's a lot of stuff going on. So it's difficult for, have been difficult for the population to really trust providers all the time. Also, one thing that is very important is like, as I said, like I had people thinking about also that why Latinos and Black patients were more affected. That also created many fears that people were, for example, like I had a patient, of course, he's an asylum seeker from Venezuela, and he has his own history of being like trauma and being prosecuted, but he had the fear of like, he lived close to Umber Hospital, and he said like, I will get sick, I will not go there. They are letting patients die. They are like, they will intubate a patient who is white, but a Latino, they're going to let him die. So that were the thoughts of many people in the community, because they're saying, oh, why our people are dying more than others? Why is this? So all this, and that has a significant, and the thing is like, the more anxious we get, the more down, then also our immune system is lower, so we are more vulnerable to the disease. So it's like a vicious cycle, and working together, this is going to be very important for the present and for what is coming. Next slide, please. This one I just wanted to, so I was talking about the illness itself, but we all know like the Latino population has been impacted, especially the socioeconomic impact has been tremendous, because many of them also have informal jobs. They didn't have sick leave paid, and many of them, like, so many of them, they felt like there was a major threat to their financial situation. Many of people, like for many months, they were unable to have a job. They still, maybe many of them are unemployed, and they provide their families here. They provide their families in their other countries. So this was like, I would say like, it's the perfect combination for a disaster, and also the support system that you usually use, you cannot use it. Like in Latino family, the personalism, being together, is something that helps, one of the protective factors. And fortunately, like the technology is helpful for the people who can use it and like it. So like video calls, but for example, we had in our clinic, like we have some geriatric groups, we have to stop these geriatric groups, and we couldn't get the patients to do like video groups. And these patients were isolated, lonely. So they were like really more depressed and also afraid to leave their house because they were like over like 75. So all this had a major impact. And I'm from the public system, so we work with many patients who don't have insurance. But I know that many people were very afraid of the cost of going to a hospital. They needed to be to explain, and this happened a little bit like in New York. I can imagine like in other places outside New York or California or Pennsylvania, where the insurance issue is completely different and they're really unprotected, unfortunately. The next slide, please. So I was mentioning this. So again, like resilient factors like churches, senior centers, psychotherapy groups, they had to, so the idea has been like to the places that have been able to be creative and that were able to do Zoom, that is not the same, and the patients were able to enroll, that has been helpful. But there is a here an inequality, as they were talking. Like, not everyone has smartphones, not everyone, like I have patients who don't have cell phones, and also like the instructions, like how to, because for example, like we are mental health, so we are very careful about HIPAA. So it's not just Zoom, has to be WebEx, has to be this like very complicated. And also they are monolingual Spanish. It was very also, has been difficult for them to help them to navigate, and also the shortage of staff. So we are trying to provide care. We have many patients, but also this kind of like, that the system is not as quick as is in the office, or many like administrative tasks that hasn't been working. So all this has affected not only the community, but also the providers. The providers, I think I have it like, maybe I go to the next slide to talk a little more about what has happened to the physicians. Oh, maybe so this is just, this is from the CDC. Of course, we still need more data. I think like if we have better data, the numbers will look different, but even with this, we can see that the Latino population and others, they had a significant increase in anxiety and depressive disorder. And we can say that it kind of goes with the, for example, here with the peak of the pandemic, but really still we need more data. If data is missing for the COVID diagnosis, we need even more data with the mental health. Still we need, we have a long way to go. Next one. Here is just saying like, just the gap. So without COVID, 68% of people who needed treatment, they're currently not receiving treatment So we can imagine how is the current situation. Many clinics, for example, in the Bronx, CHQCs, they closed. Many psychiatrists, they were older, they retired. We have many, like, also we lost workforce, and when it's more needed. Next slide, please. We can go to the next slide, maybe. So here, I was also a volunteer for a physician support line. And this is very important because we are trying to take care of patients, but also we were affected by this. Like people like Dr. Montano would say, people in internal medicine who were in ICUs, like they felt like also like helpless, feeling like so many patients of them were dying. Like it was also traumatic for them. Also, they were afraid of their own safety, lack of PPE, if they will infect their families or their loved ones. So there has been a lot going on. And and we need to do like self-care so we can help others, but also we need to be kind of supportive of each other. Like ask everyone, like, how are you doing? Because these are very critical times and there is a fatigue. This has been going on for a long time. So when we talk about behavior, people are also getting tired of following the guidelines. So we need to like a way to do an aggressive education, but also more incentivized, like in a creative way so people follow. And as I just wanted to mention this because this is very important and people are telling me this, and I have seen the change of how they were following instructions before, like 3 months ago, and how they're doing it now. And this is not the time to stop wearing masks. I know that we are short of time, so I don't want so you have any questions, you can ask me later. So most important, we need to work together.
Thank you, Dr. Montano. That was really great. I'd like to move along. I think mental health is very important for our last two speakers, and then we'll open up to questions. I want to introduce Dr. Daniel Garrido. He's a PGY3 of internal medicine at Thomas Jefferson University Hospital, and welcome your perspective. Thank you.
Hi, thank you for inviting me to the panel and great presentations. It sort of culminates into my experiences, and that's sort of what I wanted to talk about. Just in brief, I'm originally from Miami, and I moved to Philadelphia. I grew up in a family where, you know, I was close to my parents, my grandparents, my great-grandparents, my cousins, cousins, the whole shebang. And I sort of left all of that, and I came to Philadelphia to train, and there was really nobody I knew, and I had to sort of make my own family. And I bring that up because when this coronavirus first started, the whole feeling of social distancing, it was difficult for me myself as a healthcare provider, knowing how essential it is. And then sort of bringing it into this first anecdote of a patient that I had actually the first patient I ever had was Hispanic that I encountered with coronavirus. It was in the unit. He was a Hispanic male, an essential worker, and he lived in a multi-generational home. He had a respiratory failure, and I had to call the family to notify them that he had coronavirus and intubated, to let them know. And obviously that was devastating news once they knew that he was intubated. And the first response is, when can I come in? Unfortunately, the hospital policy was really nobody can come in. And I could just sense the frustration on the phone. And it was with myself as well, because there's nothing more important in this kind of culture. You want to be with somebody, even just normal family, you want to be in with them. And just even the struggle that I had myself with my co-residents, who I consider family myself, I struggle with that. I couldn't even imagine a family member saying, you know, my husband is intubated, they have coronavirus, I hear all these terrible things on the news, I need to be there now, I don't care. And that was something I sort of had to address, but then it kind of evolved. And then the second question was, wait a second, well, my parents live in this house as well. What about them? Do they need to get tested? Do I need to send them to the hospital now? And this was in a time when everything was kind of evolving and we were just learning about this new disease. I was only involved in journal clubs, and all we would hear about the new trials that were coming out of China, because that was all the data that we had. Now in retrospect, we have more information. I think at that time, that was the time when they were at that time recommending no masks, and then sort of changed. So we were all in a flux and we were in an uncertain state. So I didn't really know the best advice, but that was sort of the first time where I realized there were all these factors that could increase the risk in a Hispanic population. And secondly, I had another patient about maybe a couple of weeks later, where I came onto a service and the patient just so happened to be diagnosed with coronavirus, and it was a Spanish-speaking only male. And we were preparing the discharge information, getting him ready to go home, and I was explaining to him, this is what it means to have coronavirus. This is what it means to quarantine. And he would say yes, and this is even in Spanish on the phone, because most of the providers were having difficulty communicating with him, even with the translator phone, because it wasn't sort of clicking. And I would speak with him, and it sort of wouldn't stay with him, to the point maybe a couple days later, I said, let me check in on him, make sure he's following up with these instructions. And I spoke with his wife, and I found out even with that, they were having difficulty. And I realized one of the barriers is the information that I've seen, and I may be wrong, but the information that I've seen, it's very limited. If I Google coronavirus right now and sort of the recommendations, most of the information I'll find is in English. It's very difficult to find that in a translational, patient-centered format that a patient can understand in terms, what does it mean to quarantine? What does it mean to distance? When do I need to know when to go to the hospital? And unfortunately for individuals who are not as health literate, that creates a challenge. Which brings me to my third and final part, the resident clinic. We have a resident clinic called Jefferson Health Ambulatory Practice that's run by the residents. It's for an underserved population. A lot of them are minorities, Black, Hispanic. And what you see is, as everybody knows, Hispanics unfortunately are increased risk for diabetes, obesity, which are comorbidities that are associated with poor outcomes with coronavirus. And what was interesting most recently in our clinic is there was an initiative. I don't know if it was a new study or something from a government agency, but we created a new thing where individuals who had uncontrolled diabetes or uncontrolled hypertension that were Medicare, we gave them iPads. And we said, we educated them, what does it mean to use an iPad? And the point of it was to create this relationship with them where they can come to the clinic or through virtually, essentially, with the iPad. Because unfortunately, not everybody's able to come to the clinic. They have essential jobs where there's poor hours, they're not able to follow up with the doctor. It's not as easy to get an appointment. So I found using the iPad as an essential tool to get with them. Mind you, it's not something feasible for everybody to get an iPad, but I just thought that was something that was a unique way to virtually connect with the provider. And I know that's something medicine is gearing more towards the virtual aspect of medicine to get to appropriate care, making sure they're getting the adequate resources. So just kind of to wrap it up, the main thing that I learned out of it, especially out of training, I would have never expected 3 years ago to sort of face the crises that I'm facing in my training. Never would have imagined this. But what this taught me the most was that really managing coronavirus. I know I was reading articles and research of how to manage in the hospital, remdesivir. It made me realize managing coronavirus doesn't begin in the hospital, it begins at the home. It begins with treating these comorbidities of diabetes, hypertension, obesity, teaching how do we give them the adequate resources that are patient-centered, linguistically appropriate for the patients. If we begin there, hopefully we can start to see this discrepancy with Hispanics getting affected with coronavirus ultimately trend down. And I sort of just wanted to end it there, and thank you for your time.
Thank you, Dr. Garrido. That was really good to understand that experience that you had. And our next speaker is Sergio Sandoval-Tovar. He's a medical student at Thomas Jefferson University Medical College, and you're on.
Hey, thanks so much for having me. It's an honor to be here with you all today. Special thanks to Dr. Ludmir for sharing my name to you guys, and I'm happy to be here. First of all, I know this discussion was meant to share our experiences in terms of how our personal experience has been on the front lines dealing with COVID. And I want to share with you all that as a student, we largely have been sidelined. And I think this comes from the perspective of hospitals trying to reduce liability, the medical schools trying to protect their students, and as well as the safety of the future of our profession and taking care of our students that play a larger role than having us participate in COVID care. And so even though I've been on the sidelines, I've been able to reflect a lot on my experience as a medical student, and especially as a Latino first generation medical student. My understanding of medicine really started with student free healthcare clinics that are frequently run out in the community, usually by very self-giving, altruistic people such as Dr. Ludmir. I have his picture here. And then the people I met at Puentes were also just very, very self-giving and wanting to support the community. And that's been my experience with medicine. And I realized that with COVID, due to the fact that a lot of these places have been closed down in the last few months, that provides less opportunities for future students to have the exposure that I had in the past in terms of gaining experience in the health professions and being able to make an impact on your community. That I feel like that's largely an effect that will play a role in the future and something that we should all be cognizant of, especially if these clinics continue to be closed. And next slide, please. The other thing I wanted to talk about is the significance of the virtual experience. During medical school, I was involved with the Office of Diversity and Inclusion at Jefferson. And my main role was to try to increase recruitment of medical students to medical school. And a lot of that was face-to-face during the medical interviews that medical students would participate in when they were visiting campus. And I realized that now that'll all be changed this year. Even as far as the match for myself, since I'm a fourth-year medical student, that's all going to be virtual. So I think in terms of the virtual experience, being involved on social media and as Latino providers, acting as mentors virtually will play a more important role. And this is someone that I've been in communication with and I've looked up to in the past, Dr. Michael Galvez. He's participating in this e-shadowing platform that will hopefully try to recruit and bring more of these underrepresented groups to medicine, which will be the future. So it's important to maintain these social media outlets and create impact to our communities via Twitter or Facebook or Instagram. So next slide, please. And the other thing that I realized is in terms of personal impact, I recognize that a lot of people listening in and the participants here on this discussion today, we have an additional challenge in that our families are typically separated abroad, and especially like in thinking about my own family, my grandparents from my mother's side and a lot of my uncles and aunts are still living in Mexico. And about a month ago, I got a call from my mom telling me that some of my family members had started to experience symptoms. And during this whole time, I hadn't really thought about them and what their experience might be during the COVID pandemic. But I realized this is a global phenomenon, and this doesn't exclude the rural communities that you might think about in Mexico. and it affected my family. And unfortunately, my grandpa started developing symptoms. And about a week after my mom's call, he ended up in the ICU, and he was intubated. And it wasn't any more than 5 days before he passed away. So I wanted to share that with you all, because I think it's important to be united with our fellow Latino medical students and residents and faculty, and realize that this is bigger than us, and any impact that we can have on our communities will carries a lot of weight. So thanks for allowing me to share that.
Thank you, Sergio. I want to say that this has been fantastic, learning about all these different experiences. And I think, you know, we're all in it together. And we're a little over time, but I feel like I've learned so much from all of you. And we are able to hold on for those that want to stay on a little bit. But I would just say, you know, for people who lost, it is a very hard thing. I have my cousin who's lost 12 colleagues in the hospital. I mean, these are the real stories that are out there. And I think the thing is, what can we do now that we're entering the second phase, a second wave now? What is the most important things that we should be doing as providers to protect our communities, ourselves, and our families? And I welcome, you know, any thoughts or comments that anybody has.
Yana, can I say something?
Sure.
I just want to acknowledge how sorry I am, Sergio, for your loss. It's really terrible, and thank you for sharing that. I know it's hard to talk about something like that, you know, on Zoom. One of the things that I think that I don't think we got a chance to really discuss is the issue of the vaccine or vaccines, which is probably one of the only, besides, you know, social distancing and therapeutics and masks. I've already had patients telling me, I'm not gonna, you know, yo no me voy a vacunar. You know, people are extreme, and I've had colleagues tell me that people are very afraid and very suspicious. I mean, we already had anxiety about vaccines prior to COVID, but now, especially because of all of the compromises of public health and science, I think that the fear and the politicization of this disease, I think that there is even more fear. One of our, I think it'll be really important for a couple of things. Number one, that Latino physicians and Latino physician organizations need to be involved in reviewing the data and the science. And what I've told my patients is, don't decide yet. I promise you that I will review all of the research, and I will, you know, unless I'm confident, I'm not going to recommend that to you. But, you know, the National Medical Association has said that they're going to do their own review of the data. And probably that's something that NHMA should consider doing as well, because our communities need to be reassured by their advocates. There's a lot of fear also about the corporate component, et cetera. So I really think that we need to think about that next piece.
Any other thoughts?
Absolutely. And one of the questions in the chat is, how do we get people vaccinated? And, you know, that's certainly a task for us. I know several of you have touched on it, but are there other thoughts on strategies?
Well, the only thing I can say is that I think, as we have heard from all the panelists, in particular about the trainees, is this issue of trust and sticking together. It is so important. I think we understand the culture, we understand the values of family, the issue of respect, who do you trust, that if you have an interpreter explaining to one of our Latina family patients or relatives, the issue of the vaccine, it's not the same. I think, in my perspective, everything starts from trust and establishing those relationships and building from there, because I'm convinced that just by giving instructions or saying something on TV, on the radio, maybe can affect some people, but not the majority. And I think it cannot be done just by in translating the material or by quote unquote an interpreter on the phone, or even virtual interpreters now that this is in vogue. I think this, for me, this has been a great experience to hear the perspective from one of our residents or one of the students. But the issue of sticking together, understanding the culture and the values, I think is fundamental. I see through my own operation at our clinic that when some students and residents go and see our patients, they say, oh, you need to get the flu vaccine, or you need to get Tdap vaccine. And most of the patients will say, absolutely not. And I go there and I just smile and we talk and we say, and almost universally, they all accept. So I think it is about the way the trust issue, at least from my perspective, from my point of view. And this is something that we as a group should address for the rest of the nation. And you are the leaders of NHMA. And I think it's important to have these Latino, Hispanic groups and educate. And we should be part of the community, not sitting in our pedestals that we're sitting here in the hospital and we're big shots, but we really have to go out there. And because I think our values are values of trust and respect and being together.
I would echo that sentiment. Especially I've seen in clinic when I'm with a Hispanic patient and they see me and I come in and I'm speaking Spanish with them, the whole demeanor changes completely, where they feel more open, more free to engage in an interaction, as opposed to they sometimes feel that if it's through the translators, Dr. Ludmir was saying, that it's more of even though that's not really the intention, it comes off to them as sort of, we're distant, you're speaking to me, you're not speaking with me. And I think that when you provide that kind of context to it, as a Hispanic provider to them, you get to have that trust, and your opinion carries great value and they take it into serious consideration. And hopefully, ultimately, at the end of the day, when there is a good vaccine, they'll be more willing to have one.
Mm-hmm. Thank you. I think I'm just going to call out, since Raul, I think you said you had some experience in actually looking to do some work, signing up, trying to increase Latino representation. I didn't know if you were still on. Maybe not.
Yeah, I mean, I think the issue of Latino representation in the clinical trials is going to be important. But then once they're out, there needs to be, I'm sure this is happening, but we need to be planning now, how are we going to roll out our recommendations to the community in this, in all the different media, including, and everybody's nervous, but, doctors, even celebrities. I mean, I think there's a role for everyone in the community to be involved. One of the people in the chat was talking about what's going to happen a year from now. I think it depends in part on who wins the election. I think that our national, the approach to this problem has become unfortunately very politicized, but unless we have a national strategy that doesn't just go for this herd immunity concept, which will mean hundreds of thousands more people will die, things will only get worse. So I really feel like this election is going to be really important, and it's a matter of life and death. And part of the other piece was about mental health. I don't know if Pamela wants to answer that part.
So what long-term effects we anticipate? Several ones. I think that all the panelists have been talking about trust. So I think that's an important piece, because right now there is a lot of fear. There has been a lot of trauma. There is a more of psychological distress. And if we want to decrease like not just the acute impact, but more the long term, we need to create like an environment of support, that they are not alone, that we are there, that they can trust, that they have people advocating for them. We are supporting each other in terms like if my patient comes and they have some experiences with other doctors, sometimes it's because of the system and they don't know. So how, you need to try to explain. And also, for example, like I have the fortune that I can spend more time with my patients than a primary care doctor physician can do. So I have more time like to develop that, like that therapeutic alliance and a deeper connection. So most likely if I tell them take the vaccine and why, they will listen to me. So those parts like help, like how this could be impact like a public health, but also children, like that was part of the question. There are many things that we don't know, but this is affecting children in so many ways, because there are also children who are like, they were reacting, I don't want to go to school, because they were like told it's dangerous to go. So the mom was telling, try to go, and they didn't want it to go, because for them they were like, no, COVID is bad, it's out there, it's going to kill me. So we really need a lot of education, but from all the ways, like schools, like get it, like collaboration with mental health care providers, social workers. So we need to really work now, because there are going to be long-term effects that are unavoidable, but how bad are going to be, we can make an impact. We can decrease and really, I don't know, maybe this could be something positive at the end, and we get better ways of working together and approaching mental health and the stigma. But there is a long road, and it's very difficult to know like what is going to happen, but we all need to work together. Like mental health is every practitioner's work right now.
Absolutely, absolutely. I think on that note, we've kept you, I think, more than almost, I think, 20 minutes since the time. So I just want to thank everyone for joining us, and really thanking our speakers. That was tremendous. It was really great. Those were all great presentation, and especially our medical student, Sergio, and our resident, Dr. Garrido. You guys really were exceptional. So thank you. And thanks to...
Thanks, everybody. God bless
Thank
you
you.
all.
Thank you.
Thank
Thanks
you
to all
all
the
very
attendees.
much for your
Thank you.
phenomenal presentations. And I hope this is a start of really us getting together to really start working on some of the things we put forward to really help our communities. So thank you all. You were all fantastic. Thank you very much.
Adios.
Take care. Bye-bye.
Good night.
Ciao.
Night.